Hello and welcome back. This is PT Talks with Dr. Steve, your physical therapist. And this is Pain Part 2, Why Pain is a Good Thing. We're going to go right back to our article here under Not All Pain is Bad. And I want to read a quote that really sums up this whole series really well, so that it sinks in. And I really want, if there's one takeaway from all of this that I want you to have, it's this: pain is necessary for our survival. It's a protective mechanism. It's an output from the nervous systems to tell us there's a potential danger to our tissues and we need to alter our behavior. Again, I just think that sums it up beautifully. And really, if you're thinking about pain from a survival mechanism standpoint, from a protective mechanism standpoint, it is probably the primary reason why our species has been able to continue. If you really get down to the root of it all. I love this next sentence here. PTs don't simply recommend a pill to turn off that signal. It's not bashing pills and medicine. I think what it's really getting at is that as a society, I think we look at pain and we want to kill it and we want to negate it and numb it. And as soon as we feel anything that's pain, we associate that with, and big pharma's wrapped up into this too, and the advertising and the way that we're brought up. And, I think, society in the backgrounds that we have, it's, take this pain pill. And what I'm trying to help people understand is that it's more than that. And that really what we have to understand is that, the pain is a signal to alter our behavior. Something's going on here. And if you're just taking a pill to kill the pain, granted, we have that option. Like, that is in 2020 and for decades now, that has been an option for a long time. But if you think about it, it's a short-term solution to a long-term problem. And if you're not getting at the root cause of this symptom, which is pain, then you're really not addressing the elephant in the room, right? So I really think that's what I want to share with people, is that we need to be able to evaluate this pain better as a society. And better evaluation tends to lead to better management, right? So instead, PTs use movement and other strategies to see how the nervous system reacts when we do something differently. And I've talked about this in my previous video. That's the joy of being a PT. I really love dialing in with people, and really deconstructing what people are doing, what people aren't doing, and finding out what's going on when you consider the whole person and everything that they bring to the table. It's more than just their knee pain or their shoulder pain. People bring however many years that they've been alive, all of that experience, their memories, their fears, their intelligence, and maybe they are medical, maybe they aren't, but a lot of people have misconceptions, and they have been told maybe things throughout their lives that they believe because they've believed them for a long time. So we have to sometimes deconstruct some things. We have to sometimes demystify, debunk some things so that people can get a better understanding of what's really going on and what's happening here, versus just take a pill. Take a pill. So I want to challenge that mentality. I want to challenge that paradigm that we've been living in for a long time. And that's what this article is really doing. And it's helping, hopefully, some people understand it better. So we get into, I really want to talk about the biopsychosocial model here. And that's what this video is going to be a lot about. We're going to talk a lot about it. Biopsychosocial, it really was born out of this idea that we have to look at everything, not just the physical or the biology. So you can see it. It's three words in one, really. So biology, and that has to do with the human, and everything that makes us up as humans. You start talking about the muscles and the bones and the joints and the ligaments and tendons, the nervous system, all that stuff has to do with our biology, right? Psycho refers to psychology. So that refers to, largely, we're starting to talk about now the brain in this series and how that is such an important piece. If you remember back to the 9 things you should know about pain, number 1, pain is always an output from the brain. So we've somewhat, the brain is super underrated and we don't talk about it enough. And that's another reason for this video series, is to talk about the brain more and to talk about how psychology really plays into people's perception of pain, their expectations of pain, their experiences with pain. They bring a lot to the table too, with their fears and anxieties, stress, mood. So there's a lot to unpack there. And then the social, that should make sense. That just has to do with people's, we're very social creatures as humans, right? So that has to do with people's social activities, right? And that could include their work. That can include leisure, hobby type things as well, fun things that you do. We kind of call these participation activities too. That could be participation restrictions or limitations, depending on what's going on. We can get into the socioeconomic piece of this too. So there's a piece there that also is definitely in tune with the biopsychosocial model and how it talks about all of these factors can contribute to someone's perception of pain. So it talks about here in the very beginning here, while anatomy often plays a role in pain, it sometimes may be a minor one. Pain has many psychological components. One misconception about it is that if you just deal with the physical part of pain, the patient will be okay. And that's short-sighted. So, in fact, fear, anxiety, and depression, and more, a lot more things, can contribute to a patient's pain. So, I think what this really stresses is that PTs, and then I think people should definitely become more psychologically informed. Fear, pain, pain catastrophizing is another. That's a big sort of word there that really just it's got a simple definition. Is that when you and I've had many clients, and this is very common. That's why I say many clients, because it's not uncommon to see this in humans. I think when you just everything's the end of the world, and people are in pain. They typically are justifiably upset, frustrated, angry, scared, hopeless. They're surrendering, and they catastrophize everything. And this is just the end. I'm worn out. I'm broken. I'm weak, and you might as well, here's my death sentence. I've had a client say that to me before. They handed me an imaging report. Here's my death sentence. And we have to help reframe this mentality a little bit, or else we're just going to continue down this road where it's mismanaged and mishandled. And we have a lot of people who are, no offense, ignorant, but that just means they don't know. And we're just trying to educate the population here and help them understand what's really going on. Anger can have a role in pain too. So think about that. I mean, if somebody's angry and they lash out, all of those emotions, all those chemicals going off in the brain, and then they can have more pain depending on where they're having it and what their situation is. So we see a lot of these things carry over and cross over because where is all that coming from anyway? Where's all that stemming from? The brain is, remember, the seer and doer of all things. So whenever you start talking about all those fears and anxieties and stressors and anger, all of those different emotions, all of that resides in the brain. So it has to handle all that stuff, plus the fact that you've got some kind of memories, experience, something actually, whatever it might be, you're having pain somewhere else in the body. And we have to sort of deconstruct that, help to categorize what's going on, see what you're doing, see what you're not doing. And that's the joy, again, of being a PT, is that we really get to dive in and spend a lot of time with people, talking, educating, just like this. And this is no different, folks, to when you start looking at how I communicate with my clients, I love the talks that I get to have with my people and educating them, just like this. And now I just get to do it on a bigger stage. So I want to talk a little bit more about the biopsychosocial model. And this next page gives a nice example. Sorry, it blurred out on the scan a little bit in the center. So I'll read it and help paint you a picture of what's going on here. And we start talking about the biopsychosocial model. So basically what happened here is they chose this patient because she had many risk factors. She had chronic pain upon presentation. Again, remember, that's pain that's lasted longer than 90 days. She had been involved in a car accident. If you've ever been involved in a car accident or know somebody who's been involved in a car accident, it's not fun. Typically, these are really tough cases to manage. Lots of pain, lots of problems, lots of litigation, stress, anxiety, you can imagine, between lawyers, insurance companies, healthcare, work, missed work, finances, all the just fun things, right, that come from this situation. So that need to be dealt with, but a lot of people don't know about them or know what to do until they're right there in the whirlwind of it all. So she, this client, previously experienced anxiety and depression. She had received cognitive behavioral therapy for it, and had not had medical management. So she was receiving cognitive behavioral therapy, no medicine for her anxiety and depression. And her grandfather had recently passed away. She had neck pain, but it wasn't typical neck pain that we would maybe define as classical type neck pain presentation. It was atypical. Paints you a picture of a person, right? So it's more than just this person has neck pain. Okay, look at this entire, and this isn't even, and I wouldn't even say this is comprehensive, but this is starting to scratch that surface and pull back some layers, right? We've got a history here of some mental distress. We've got some maybe recent history here, right? Recently passed away, a grandfather. Put it all in the pot and stir it around, as I tell my clients. There's all of this happening simultaneously with the car accident now, new stressor. The patient presented with risk factors for chronicity and with a pain picture that indicated she didn't have purely nociceptive pain or purely central sensitization. Big words, don't fret, don't stress. We'll get to these in future videos too when I break down chronic pain a little bit more. This just has to do, she had a mix of both of these types of pain. These are types of pain. Really nociceptive has to do with your ability, really is free nerve endings in the body are really picking up on some kind of stimulus, some kind of situation here where it's sending signals to the brain. Remember, the brain is the output for pain. Central sensitization is not nociceptive in that sense, where it's that you're sensitized. Your brain is, in fact, sensitized, and it doesn't even necessarily need to get any information, or the information that it is getting is potentially getting skewed or smudged, or it's just not picking up the situation accurately, and it's sending pain signals out because it's anticipating pain. Remember, we've talked about that in the last video too. It's anticipating pain. There's a potential for danger. It has to do with all of the other inner psychological workings. And we see, just so that you can follow along a little bit easier, central sensitization usually has a lot more to do with chronic pain. So it's usually you become more sensitized, like nerves or body tissues have healed in a more hypersensitive state. That's where you see central sensitization. It's a sensitization, or things are sensitized, hyperreactive. So, the first step was to build a therapeutic alliance. It really got to know the person. Really, I really, this evokes kind of like a warm feeling. It evokes that warmth of getting to know someone. It's not just cold and a sterile environment and just a wall between you and the patient. It's more about, really listening, active listening, caring about what's going on. That can't be overstated in helping people, is that I think the people might not know what pain is. They might not know what nociception is or central sensitization, but people generally they have good radar. They know whether or not you care. And I think that's been another part of my job that I really like, is that when I work with people, I hear this time and time and time again, is that thank you for caring, and thank you for showing me that you care. And I think it's not just it's not just saying I care, it's the actions that you do, and it's the fact that you enjoy what you do, where people are more able to pick up on that. Like, you really like what you do, because I'm typically just firing, here we're 60 miles per hour right out of the gate, and we're just educating. And I want to find out where people are, and I want to meet them in the middle somewhere so that we can make some progress. So therapeutic alliance. He was careful not to use language that might scare the patient when they discussed her physical condition. That's another way for saying all the medical jargon words. It doesn't make any sense to you. Nociception and central sensitization and degeneration and, wow, you're, grade 3, grade 2. It just, lay people, non-scientific people, non-therapists, non-medical, professionals really just don't use this language a lot. So when they hear it, it's like, big bad words, this is not good for me. And really, it's just medical jargon. It's just another language we've developed so that medical people can talk to each other instead of us saying what all lay people say. We had to create another language that just sounds worse than it is. And I think that's what has happened over the years too, is that a lot of this carries negative connotations, when we're finding with a lot of studies coming out that there are a lot of normal instances where these things are happening in the aging human, and it's not uncanny to see across populations with and without injury. It's just normal. A lot of this is normal aging, but it's important for people to, you meet somebody on their education level, and you meet somebody where they are with these words. And so he didn't use medical jargon that was over her head and that made her, I don't know what you're talking about, but this sounds bad. And she had begun to avoid movement. So instead of doing just a lot of manual or hands-on therapy, what did the therapist do? Found some movements that made sense and made this person feel good. Likely, it doesn't say this, but I'm going to guess here, just from experience and knowing what I know and knowing what I've read here, is that they felt good and the patient was able to do them. And the patient was able to do them, potentially finding relief, but more importantly, even if not finding immediate relief, they were able to do them and their pain didn't change and that much. There wasn't a spike, there wasn't a huge increase in pain. So that's important too. It's important about prescribing the right thing for people, not just, all right, you're in a lot of pain and we're just going to do manual therapy where you just lie here completely still. My argument there is that can be important, and that can be a great caveat to your treatment, but it can't be the majority. It can't be everything, because you're not going to help someone move better if they're laying still, and that's all they do. So this next piece is really important, and we can, again, it carries over to a lot of different things. But this person, after the accident, they were in their car, and they had an increase in pain when they got to the scene of their accident. So they're driving. This is after the accidents happened. They're driving in their car, and they stop at the stoplight, and they realize this is where the accident happened, however many weeks, months ago. And it triggers their pain. And you step back and go, well, that's interesting, because there was no physical reason, right? There's no forces. There's no other physical stress. There's no other, physical explanation why suddenly they would start having pain. What is it? And you already should be answering it. It's the psychological piece. It's the stress. It's the memory, that experience that they lived through there, and the fact that they're sitting at that scene and it just conjures up all of this. It's usually negative things pretty soon, and for a while after a car accident. It doesn't start getting positive where you start talking about, I had a great physical therapist, I had great doc. You don't really get there maybe after a car accident until many months down the road, because you're just in it and you're just in this cyclone of just it's tough. It's really tough. It's definitely it's a tough situation with car accidents. But I bring this example up because it carries over to a lot of different things. And you start talking about the conjuring up of different memories and experiences and your expectations that then can drive certain pain episodes where you go, I've had so many clients over the years just almost answer this, but not have this piece to in the middle to be able to understand how they got from A to B. But when they say to me, I barely did anything, and then my knee or my shoulder or back, fill in the blank, whatever, started hurting, and I barely did anything, but I was thinking about my pain, and I was thinking that it would hurt. I'm like, that's the gap, that's the bridge, right? And so, one example that's come up forever, I love working with my geriatric population, but the stairs are an example that comes up all the time. And I can't tell you how many people I've been able to treat successfully who've had pain in their limb somewhere in their legs doing stairs. And we get to start practicing on the stairs after we've been in therapy for many sessions, a couple weeks, whatever it might be. And we get to the stairs and they go, this is going to hurt. And I go, sir, ma'am, what's your pain right now? 0. And so the expectation is there already. They have a memory. Why else would they say this is going to hurt? They have a memory that stairs hurt. So now stairs are going to hurt forever. And it's really about breaking that cycle. It's really about helping people to bridge that gap, understanding, but then having positive experiences. We've got to somehow, this is what the Therapeutic Alliance is all about. We have to help bring in the positive experiences and completely overcome that, but just fill in and flood that gap from A to B for people with positive experiences, so that the norm or their default isn't this ABC, XYZ, whatever it might be, is going to hurt. So psychological, social piece, really important. And that's what the biopsychosocial model is all about. So this patient, in the car accident, actually ended up doing really well. In the course of 5 visits, they saw a significant improvement in her neck. Her pain response at the accident scene improved. During her first visit, the patient reported her pain as 7. By the 3rd, her self-reported pain was 0. So she, lo and behold, she did well. Acute symptoms may go away pretty quickly, so that wasn't too surprising. But what we did not do was as important as what we did do. We did not show her pictures of where she was hurt and say that those were things she needed to avoid. Instead, we told her that her body was resilient and could overcome the pain. And the messages that you convey to people are really important. Showing people pictures of what their body looks like doesn't really serve any purpose to helping people overcome, right? It's just an internal picture of what your body looks like. It's most of the time what we're finding, we're going to talk about this a lot more in future videos, but we're finding with the studies that are coming out, the way that your body looks on the inside does not dictate how you feel. It does not dictate pain. And so it's a really important blip on the PT and medical radar, because it's how we've been functioning in medicine for a long time. Is that, you see that this is a scan, shows this right here. We have to do, because of this, we have to do, and it points to how we treat further down the road when really it's just a picture, and it's not a moving picture. It doesn't show us function. It doesn't show us the person. It doesn't show us their lives. It doesn't show us their psychology. It doesn't show us what their fears and anxieties are. It doesn't show us what they're not able to do. It's just a picture. We're going to talk about that a lot more in future videos, though. So, I think the next piece here is we start talking about one more thing. Listen to this sentence. This includes posters and models of ridiculous bulging discs you have up in your clinic. Instead, we need to provide people with experiences that are inconsistent with their beliefs about pain and their brain's automatic conclusions about the danger involved in movement. If you've been to a doctor's office, you've probably seen something where it's like there's they take out like two vertebrae from the back, right? It's just a model, right? It's a little plastic model. And it shows this big old red herniated disc. And it's just bulging and falling out, and it looks awful. And it's like, what is that doing for us in our healing timeline? What does that image convey to us? It doesn't do anything. When in fact, we know that the majority of those herniated discs, given time, given the proper treatment, will heal. They will reduce. So it's interesting. It's just, again, visually what we see in every other sense, what we see, what we hear, turn us into a species, a being here that has expectations. And if we can help people reframe those expectations into really what matters with some encouragement, right? That we are strong. We're really strong species when you think about what it takes to hurt our bodies, like actually damage our bodies. Good things can come. Really good things can come. And I'm coming at you from an angle where I'm speaking from experience too, and working with people, and my personal life with things that I've dealt with personally. So we're going to continue in the third video, talking about fears of movement, and how to kind of get through those, and talking a little bit more about the psychology as we dive in and wrap up this video series. This has been a lot of fun for me. I hope that you're enjoying this and learning something. Again, post any questions or comments that you have down below. And please like and subscribe if you're enjoying this content, and turn on notifications. And this has been PT Talks with Dr. Steve, your physical therapist. And I hope you stay safe and take care, and we'll see you in the next video. Thank you very much.